Let's analyze this case. The patient has a PSA that is not suspicious because it is a PSA of 2. This patient is 76 years old, but this patient had a transurethral resection years ago. And in this case, as we all know, when the prostate volume is reduced, the PSA should decrease. The current PSA is 2 and has more or less remained stable, but he is a patient at risk, both his father and his brother. So we have a high-risk patient who might have prostate cancer, although the PSA in this case is not very suspicious, but nowadays with a high-risk patient, it's recommended to do an MRI. Here we have the exploration that has been performed on this patient, and we have the key axial images, the T2, diffusion, and ADC. A prostate that is already very reduced in volume, the prostate that determines an increase in its volume is the transitional zone, which in this case, the transitional zone, as we see, practically has no transitional zone left because it was the one that was resected due to the hypertrophy it had in the past. And we have the peripheral zone left, which we must, and it's the region where 80% of cancer is located in the peripheral zone, which is what remains. It can sometimes cause us problems if this heterogeneous area has any lesion. The T2 is very good for anatomy, but the key sequences are the diffusion. And complemented with the value of the diffusion coefficient, which are these two images that we should complement with the anatomy. Here, we must assess if there is any clearly focal, very hyperintense lesion, and it should correspond to a very hypointense lesion. But we must evaluate because small lesions can influence us or might be suspicious lesions. Very small, which corresponds in this case to hyperintense, and yes, if we analyze well in the periurethral zone, we must complement with the anatomy here in the very anterior zone, which is not the most common area to find lesions. Most lesions will be in the posterior area, but here we have it in the anterior area. The PI-RADS is markedly hyperintense, markedly hypointense, and if it is markedly hyperintense, markedly hypointense, we have a criterion already of PI-RADS 4. But of course, we all know we must avoid overdiagnosis to avoid actions that in this case can lead us to a benign lesion with what might influence performing biopsies that are not necessary. Or if we can complement in this case that it is, and we have the possibility of having an application that shows us with artificial intelligence if this lesion is clearly suspicious or not according to artificial intelligence. In this case, I will assess if this image, which may be suspicious by PI-RADS criteria, but it is so small that we have our doubts. I have my doubts. And we confirm. The artificial intelligence is clearly showing us in the same location where we had confirmed there was a lesion. It confirms that the artificial intelligence indicates a suspicious lesion, and in this case also marks it with the color of high suspicion. Clearly, we must determine that we are facing a suspicious lesion. The report clearly indicates that a biopsy should be done. And locating this lesion prior to the peripheral zone and clearly seeing these images that it is suspicious. Within the resonance, because it is within the resonance where we see the images, which is what we are seeing now. We have inserted this guide and the needle, and we are taking 2 centimeters of prostate tissue. The 2 samples obtained confirmed a Gleason 3+4, that is significant Gleason, which means it requires doing an intervention or an action. In this case, active treatment, total prostatectomy, and complete resection confirmed a Gleason 3+4. Detection with resonance, biopsy, and active treatment for, in this case, a localized Gleason of moderate risk, 3+4, 100%, 5-year survival after the intervention, after the diagnosis.